Dr. C.R.CHANDRASEKAR, BSc, MBBS, MD, presently practicing as consultant psychiatrist in Venkateswara Hospital, Nandanam, Chennai. He also has his own clinic in Raja Annamalai, Chennai. Dr. Chandrasekar is a senior consultant who started his practice in Chennai in 1981. He was attached to and visiting a number of hospitals mainly in South Chennai. It included Devaki Hospital, St. Isabel Hospital, Apollo Hospital and Malhar Hospital. Between 2000 and 2021, Dr. Chandrasekar was away from India. He worked as a specialist psychiatrist in Brunei and later in Australia and New Zealand. For over 11 years, he worked as a consultant psychiatrist with Waitemata District Health Board, Auckland, New Zealand. He returned back to Chennai end of last year. Dr. Chandrasekar hails from Coimbatore. He completed bachelor's degree in chemistry from PSG Arts College, Coimbatore. He secured his undergraduate degree in medicine from St. John's Medical College, Bangalore, and postgraduate qualification MD from Postgraduate Institute of Medical Education and Research, Chandigarh. Dr. Chandrasekar's main area of work has been in adult psychiatry. His experience in Australia and New Zealand helps him to focus on the following. He strongly believes in GP's role in long-term management of patient care. He encourages patients to have his or her GP. He would like to maintain an ongoing liaison with them. Aim is to transfer patient care to GPs as and when they can take over and offer continuing support. Psychoeducation of patients and families. Importance on adequate documentation of clinical work.
Thank you. I think Professor C.R. is in his hurry to finish the lecture. We've forgotten one point. Among the modalities of treatment for depression. Among the modalities of treatment for depression, one is listening to a talk. You should have added that one. I'm very happy. When Dr. Pillai asked me to choose a topic, thanks for giving me the opportunity, and thanks for all of you to come here. But when you asked me to choose a topic relevant to the situation, particularly COVID, anxiety, I was thinking something else. I was thinking how to connect with GPs more, but that's singularly lacking. We are in our own shell, and GPs are their own shell. They refer the patients to the doctors, and there's no liaison, there's no continuity. and Professor C.R. has pointed out that how GP should take over. So this is in continuation with the same theme, how the GPS can play more effective role. So I chose the topic schizophrenia, even though the schizophrenia as such is nothing exciting about it. But there are specific areas in schizophrenia where GPs can play a role. It may be a little premature for Indian situation, but abroad, I think New Zealand, I was there for 11 years, in Australia. Most of the stable psychotic patients looked after by the GPs, particularly people on clozapine who have been well for 2-3 years. They just go to the GP and then follow up, come to the psychiatrist as and when necessary. So that sort of concepts are not here, and that will make it easy for a number of reasons, which we'll discuss. Yeah, so schizophrenia, as such, the role of the family is shared. One is for early identification. Particularly, the illness is insidious. It doesn't start suddenly. Then it gets neglected, or people don't identify. They don't come to the doctor. They take a long time, and they miss out. It has been proved that early diagnosis results in early recovery. And so one of the important roles is to encourage family to seek psychiatric treatment early when they suspect the psychosis. Then, over a period of time, all the antipsychotic medications, they have physical, they cause comorbidities. They cause metabolic syndrome. They cause hyperlipidemia. Many of them have diabetes, obesity, and all those things. So, and it's also known that psychiatric patients' physical health is neglected. Usually, is not earning that much as a neglected person in their family. So, if he falls ill, they don't take him to the doctor as much as an earning member would do. So, they do have a lot of comorbid physical health issues. and the GPs have an ongoing role to treat them. And all you feel that most of the psychotic patients, chronic patients, they drop out. They keep on doctor shopping. They drop out. They don't take medication, and they just lost periodically, and that's not good because they get worse and worse. And that's where the GP family physician's role is very important. So they can talk to them and find out what's the reason. Is it a cost reason or whatever reason is that, side effects of the medication? So they can liaise with the specialist and see that the patient is on a regular treatment. So GP remains the link between specialist, patient, and the family. That's a very important thing. And lastly, this is what I want to focus today, is that the specific situation where when the illness is stable, the psychotic illness is stable, the person may have low-grade psychotic symptoms. That's okay. Just because he's hearing voices doesn't mean we have to panic or do something. He may be stable with that. He may be taking some medication, so they can continue to function. So some of these chronic psychotic patients who are stable can be treated by the GPs with the support of the psychiatrist. Yeah. So we talk about focus on treatment-resistant schizophrenia. So this is one illness where, when they are stable, the GPs can take over. The treatment-resistant schizophrenia is the schizophrenia is diagnosed, and it's always, I think, that specialist has to make the diagnosis because the long-term label. So family physician can suspect schizophrenia, but it's better to get it confirmed by the specialist, and more so treatment-resistant schizophrenia, which is defined as not responding to antipsychotics, like risperidone and olanzapine, sufficient dose, sufficient period of time. When they don't respond, then deem it as a treatment-resistant schizophrenia. And again, the diagnosis is best made by the specialist psychiatrist. So the treatment for treatment-resistant schizophrenia is clozapine. Clozapine therapy is quite simple, and it's a very protocol-driven. It's very highly protocol-driven. You do the A, B, C, D, 1, 2, 3, 4, 5, 6, 7, 8. Do this. If it's green is there, you do. It's like that, basically. So the specialist can initiate the therapy. You need to get the consent of the family, consent of the patient, and lots of routine physical examinations need to be done, like routine blood count, all those things. But the treatment is often almost always started in the patient setting. They are there for 2-3 weeks at least, and then gradually the dose is increased and the patient is stabilized. I'm not going into the details of this because it'll be done by the specialist. You don't really have to think about it much. Yeah, who are the patients who are suitable for GP follow-up? Patients who go to the specialist, they try different medication, they don't get well, they put him on clozapine, they settle down brilliantly. Sometimes they brilliantly settle down. They don't respond at all to other medication. They're in the hospital all the time, and then clozapine fixes the problem. So when they are stable under clozapine, you increase the dose, you have reached a particular dose, and they are stable, and you're continuing the same dose for 6 months, 1 year. So hardly requires any further adjustment. The side effects are also minimal. They're okay, and mental health, mental symptom, mental state is stable. Then that may be the time the specialist may think, okay, there's nothing much actively we are doing. We're just monitoring. So why not we refer to the GP, who can see frequently and follow up and contact the specialist, as and when necessary. But when I think that's where I want to focus. Now, there should be good connection between the specialist and the GP. It's lovely, particularly when a person is on clozapine. I mean, GP should be able to talk to the specialist like that. Suddenly the count is low, what to do, or something else. He's not, bowel is not moved for the last 4 days. Is it a crisis? What to do? I think in a good system, there's always an immediately available service. And I feel that you must have contact the specialist service with a phone call or a WhatsApp. Nothing wrong in WhatsApp with the specialist for clozapine patients. The doctor is familiar, and it's just one word. You just tell that, and we tell this is what you have to do. Then you're safe, you feel comfortable. So, if the GP is well supported by the specialist who is available on telephone or email or preferably WhatsApp, and they can get an appointment if required, and there's a hospital backup if requires immediate admission, say low WBC count or infection or constipation, has to come to the hospital. It's good to have a hospital where the psychiatrist is attached to and familiar. And also, in New Zealand, it's only dispensed every 4 weeks, particularly after 18 weeks. Up to 18 weeks, it's a weekly blood test and weekly dispensing. After 18 weeks, it's 4 weekly blood test and 4 weekly dispensing. And the pharmacist will not dispense if you go. And he will ask you, where is the blood test? And if it is low, if it's amber or thing, he'll give a call to the doctor, I don't. And also sometimes it'll be green, but still if there's a big drop, like the WBC count has been 8 or 9, and then it's come down to 8,000. You come down to 5,000, even though it's still green, if there's a rapid fall. In other words, they're so tuned, that's what I'm trying to say. Pharmacists will quickly, go to a doctor, get it. Of course, we don't have those systems, but it's possible to have GP and pharmacy connection. And, so that is one requirement. Yeah, why GP follow? See, in a stable schizophrenic patients who are on clozapine and doing well, what is really required is a physical health follow-up. Mental health is a little up and down, but he's okay. Few days it may be a little bad, he's okay. What is really required is a physical health follow-up. You can have a slowly developing a cardiomyopathy, or you can have suddenly the blood count is low, and the infection. And so it's a physician's job actually follow up. And mental health, if it's concerned, you can have just a word, Dr. Chandra, what to do with this guy? He's not doing well. And how is he doing? Okay, send him after a week, no hurry. So it easily can talk the mental health problem. But the physical health is what you have to monitor, which is a very simple, straightforward, response. So it's a good, connectivity. I chose the topic mainly because of that. There's a good connection between GPs and specialists, and this will encourage GPs to take more interest in psychiatry. You get a chance to talk to us and we discuss. You'll find more interesting because you feel secure. If I don't know anything, the doctor will help me. He will tell me something, so I don't have to be panicked. And that sort of a collaborative thing we have to build up. Which is not here. You refer once and you forget about it. What's happening, you don't know. So I feel that it helps the importance of collaborative engagement, especially as GPs, particularly in chronic people who are unwell for a long time. Also, it helps people. Patients will not doctor shop. So once they go to the GP, then they will go to the GP regularly. Cost will be less, and so many things will be better, and follow-up will be much better. And people who have regular GPs always do better than people who don't have GPs. Very clear. So the routine protocol is for the first 18 weeks we do blood count. Particularly what we are worried about is granulocytopenia and neutropenia. So we do every 4 weeks, every week, and then after 18 weeks, every 4 weeks. And the protocol, if it's drops down to amber, then you have to do something, every 2 weeks, the blood test and things like that. If it is red, then you have to stop it. And there are routine tests, the annual ECG and the weight gain. These are all simple things. And, once the GP is trained, usually what we do is that when the GP shows inclination and he wants to ready to manage these patients, we can have a training for them. A short period, they know what to do. So some of the side effects is what they should watch out during follow-up. One is sedation. Clozapine can cause severe sedation sometimes, that the patient may not be able to function. Say, Doctor, I can't even go to work. So that may be a situation where the medication has to be decreased. That's where probably you have to have a word with the psychiatrist and ask if you do that. And constipation can be a serious problem. There are people who have died of paralytic ileus, clozapine-induced paralytic ileus, because of atropine effect, which is underplayed. We didn't know that before, so much. We are only worried about granulocytopenia. Constipation can kill. So, in fact, it's routinely laxatives are prescribed for clozapine patients. Routine laxatives, and make sure they go it moves every day. And if they don't go for 48 hours or more, then you have to do the next step, what to do. So they have other side effects like hypersalivation and seizure in high doses, 500, 600 milligrams or more. And some serious side effects. The myocarditis is mainly in the beginning, in the first 2 weeks, first week or 2-3 weeks. But cardiomyopathy is the long-term sort of complication. So the thing is that clozapine is the gold standard for, there's nothing better than clozapine. If people has not responded to other, schizophrenic patients not responded to other medication, clozapine is the only option. And, but as you see, patients have not responded. But use across the world varies for a variety of reasons. In New Zealand, Australia, it's about 25% is clozapine is used among, schizophrenic patients. But in US and other places, Japan, see, there are lots of other things. Like in India, it's very difficult. I can't start a person on clozapine knowing he won't come the next week, And in fact, even if person stops clozapine, he still must have a blood test after a week. Like if it's 18 weeks, you must still have a test after 4 weeks. So there are a lot of protocols driven, and so unless you are sure of a proper follow-up, you can't stop. And thereby you are really depriving people who will otherwise do very well. So if there's a good sort of, there's a good GP and they have a long-term connection with the family, and then this can be thought of. But I don't think how often, I'm not very sure how comfortable consultants are in prescribing clozapine here in India. So that's my focus. With the proper system, we should be able to use clozapine more often, and more patients can be benefited and have more function. Thank you.
Thank you, sir. Any questions to ask, sir?